Thank you for that kind introduction and for the opportunity to speak with you today. And these slides look familiar, so that's fantastic. So my talk today is titled The Road to Viral Hepatitis Elimination, and many of these slides will look a little bit familiar as there is some overlap with the presentations from Kay and Chloe this morning, but there'll be a slightly different tilt on them, and I hope that you find that interesting. As the bio said, my PhD was in models of care for hepatitis C. So I know when I was out of the room earlier, there was a question about why there was different uptake in hepatitis B and C in the area. So I actually took over the liver clinic in Bowen Health in about 2013. So we're nearly a decade in there. But my work research has largely focused in hepatitis C, and you'll see how that plays out. But let's start with the proper talk now. And of course, I'd like to begin by acknowledging the traditional owners of the land, the Wadawurrung people of the Kulin Nation, and pay my respects to their elders, both past and present. And these are my disclosures. And here's an overview. So again, I'd like to start with a presentation of the global viral elimination targets and then how they look locally in Geelong. And then, because I thought the agenda really did look quite hepatitis C focused, I'm just going to talk about hepatitis B. And I've linked a couple of topics together. So we're going to talk about prevention and transmission, who to test and stigma, how to test and healthcare worker knowledge, linkage to care and what that would look like in an ideal world, and then access to care. And hopefully you'll see why I've partnered those topics together as we work our way through. Then I'd like to talk about what you can do, no matter which aspect of the healthcare industry you work in, and then some conclusions. So let's kick off. A call to action. Now, this is a different format of the same information you heard earlier. So what you have here is the kind of all-star, and can you see no, right, you don't see that, right. So these are the kind of all-starring infectious diseases on the global platform, and that's HIV, malaria, and TB. They get most of the money, most of the media, and the attention in that way. But you can see what this graph demonstrates when measuring deaths in millions globally is that all their curves are flattening. So we've all just survived a pandemic. We all know what flattening an epidemic curve looks like, and we can see that those curves are all flattening. But there's one curve that's not, and that's the curve in the darker green there for viral hepatitis, and that is steadily increasing. And this was something that was on the minds of this group of people. And here's a picture of the World Health Assembly. So that's the legislative arm of the World Health Organization. This photograph in particular is the 69th World Health Assembly in 2016. So this is a meeting that is held annually in Geneva in Switzerland. And they've got, a pretty small agenda of things like, how do we alleviate global poverty? How do we make the world healthier? Really quite a lot to discuss. But at this particular meeting, they adopted the first global health sector strategy on viral hepatitis. So this was really an acknowledgement of how important this illness is, how many lives are lost because of viral hepatitis. And when we talk about lives lost because of viral hepatitis, that is really largely a measure of hepatitis B and C, and really largely deaths related to liver cancer and liver cirrhosis and complications of liver cirrhosis that were explained to you in the talks earlier. So within this strategy, there was a call for the elimination of viral hepatitis B and C as a public health problem, and they defined this as a 90% reduction in incidence and a 65% reduction in mortality by 2030. So we've got 8 years to go. And these were relative to a baseline at 2015. So they gave us some other targets as well that are programmatic targets, a little bit easier to interpret, I think, in clinical practice. And I've listed them there too. And that means that of people living with viral hepatitis, we want 90% of them diagnosed globally. And we want 80% of those diagnosed treated, and that is with hepatitis B, those eligible for treatment. And why is this possible? It's possible because we have a brilliant vaccine for hepatitis B, and we have brilliant treatment for hepatitis B, and we have curative treatment for for hepatitis C, and we'll circle back to those points again. So here is a colourful map of the world, and it's taken from a group called the Polaris Observatory, and they calculate how close each country is to being on track in achieving those programmatic targets that I just referred to. So that's 90% diagnosed and 80% eligible for treatment treated. And it's a traffic light system. So green for go is good, on track, yellow working towards, and red is not on track. So this is the global map for hepatitis C, and you can see there's some success. This data is taken from 2020. I think there's 11 countries that are in green, including Australia, which is great news. And there's all sorts of reasons why the green countries are green, and we can talk about that another day if you're interested. And here's a familiar graph. Again, this is diving down into the national data, and I love showing this graph, obviously, because we can see it's a league table, bring out people's tribal elements of pitting them against each other. Especially it's good when you're on top, which is where Western Victoria is. And there's all sorts of reasons why Western Victoria is on top, but in essence, it's because we've been working really hard with the community and all sorts of initiatives for the last, we're really since 2014. And I didn't put up papers. I thought they were a bit boring. Instead, I put up photographs. So that's the team of liver clinic clinicians with their very first FibroScan machine. And I don't have a pointer, but it's Marg Wardrop who largely led the revenue raising to purchase that machine. Marg did Inga's job before Inga did it. Inga will arrive soon. She's out at clinic now. There's Inga in the photograph at the top there, out at the NSP in Corio. She's currently busy doing the quick start study. That's why she's not here now, but she will be soon. And many of the projects we've done have been in collaboration with the Burnett Institute, which is where I also work as a senior research fellow. This photo in black and white, I love. We'll be hearing from Craig Harvey, who's the Director of Harm Reduction Harm Reduction in Bowen Health. And also there's members of the community psychiatry services there when we integrated hepatitis C treatment through the community psychiatry and needle and syringe program. So we've done all sorts of things to try and make hepatitis C treatment more accessible to people living with hepatitis C in the community. And I don't have a photograph of the 79 GPs in Western Victoria who have prescribed hepatitis C treatment, but I wish I did, because that was a great initiative. And whenever something can be accessed from a GP, we know that people are far more likely to adopt that practice. So that is some of the reasons why that league table looks good. But that is not what I'm going to be talking about today. Instead, I'm going to be talking about this, because this is where the next 10 years' work needs to be. Clearly, 25th is not a good place. But we're not alone, because when we look at the programmatic targets globally from the Polaris Foundation, I think there's one country that's yellow. It's one of the Scandinavian countries. I think it's so small you can't actually see it on this map. But really, there are not many places in the world that are really getting this right. So what's the problem here? What are we getting wrong with hepatitis B? And that's what we're going to try and talk about. So what we have here is what's called a care cascade. This is often how hepatitis B epidemiology is presented. And the first set of bars on your left is the number of people estimated to be living with hepatitis B infection in Australia. And this is data collected by the Kirby in 2016, 17 and 18. So we'll just concentrate on the orange bar because that's the most recent one, and that's in 2018. So you can see it's about 220,000 people. So the next set of bars, you can see approximately 68% of those have been diagnosed. So already we've lost, about a third of people haven't been diagnosed. And then we can see only only 1/3 of people who know they have hepatitis B are receiving care. So Kay explained to us before that not everyone with hepatitis B needs to have treatment, but everyone should be receiving care. And I'll go and explain what that looks like. But for the purposes of this graph, that means that you have had a hepatitis B viral load blood test within the last 12 months. So that is the minimum sort of care that you need to have had. And that's what this graph means. So you can see that 22% of people with hepatitis B in Australia have had that in 2018. That's really not very many. And then 9% have received treatment. And so what we would be aiming for is that 20% would have received treatment, not 100. So that's a bit of a funny thing to get your head around. But what we want that last orange bar to say is 20%. So let's kick off. We're going to now talk about prevention and transmission. So I can skip over this a bit because I think Kay has mentioned that hepatitis B is transmitted through blood and other bodily fluids. Globally, the major mechanism of transmission is what we call vertical, from a mother to her baby during birth. Hepatitis B can be transmitted horizontally between children and family members living within a household through sexual contact, sharing drugs, and non-sterile medical procedures. So how can this transmission be prevented? By vaccination. Babies can be vaccinated, but also given antibodies known as immunoglobulin as soon as they're born. Hepatitis B medication can reduce the risk of transmission, and also obviously harm reduction measures such as safe sex and the needle and syringe program can reduce the risk of transmission. So now let's look at how that lines up with our hepatitis B programmatic targets according to the World Health Organization. So what this graph shows is the grey bars say what the WHO says where we should be at, and the green or red bars are where we are at. So if we look along the x-axis there, because I can't point with a pointer, you can see hepatitis B total diagnosed. Our green and grey bars don't line up. So not enough people are diagnosed. The red bars clearly totally inadequate, not enough people are treated. But then for hepatitis B birth dose, vaccination rates, blood safety, injection safety, and the needle and syringe program, our green and grey bars match up quite well. So in terms on an Australian level, we're doing well on those fronts. And it's really those first two bars that we need to think about. So what then are the demographics of people living in hepatitis B in Australia? If we're doing so well with those factors that I just listed, the people living with hepatitis B in Australia reflect the vaccination programs in the countries that they have immigrated from. So we can see that most people living with hepatitis B in Australia have immigrated from overseas, and the most common countries are, or regions are, Northeast Asia, Southeast Asia, Sub-Saharan Africa. And there are also other groups that are at risk, people who inject drugs, men that have sex with men, and also Aboriginal and Torres Strait Islander people. And there will be an age-related association here because the hepatitis B vaccine was introduced in the 1980s, and then it became universally administered in the kind of noughties. So that means that the people who are vulnerable to being exposed and infected are older because they have not been received the vaccine at birth. So right, we're going back to our hepatitis B care cascade about who to test and also in relation to that stigma. So we know now who to test because we've gone through the risk groups. So people from a high prevalence country, Aboriginal and Torres Strait Islander people. And I'm not going to read through this list again because I really think that's been covered already this morning. But there's another idea about who to test, and that's an idea of universal screening, because whenever the list gets really long and whenever the test is inexpensive and whenever the stakes are high, like we are trying to prevent cancer here, why don't we just test everyone? So certainly there's been modelling studies that have shown, and the modelling studies were done by the group at the Doherty, the WHO Collaborating Centre, that there is a role for universal testing of hepatitis B. That's not yet recommended within the guidelines, but I think what it should say to us as healthcare workers is that we should have a really low threshold to ordering this test. If in doubt, just order it, you know? We're doing bloods, if we're not sure, just add it on. There's not a reason really to not do it. But how? Oh, yes. Oh, sorry. I'll circle back to that point later. So are we doing that? Is everyone at risk of hepatitis B offered a test currently? So this is a study done by Yingzhong Zhao, who just completed her PhD at the Burnett Institute some years ago. And she did a survey of GPs in Australia, and she sent that to 1,000 GPs, and 134 responded. So you can imagine that those 134 GPs that responded to a survey about hepatitis B are going to be the more interested people. They're like you in the room here today. You are more interested in hepatitis B and hepatitis C than the people that did not attend. And of these people that chose to answer the survey, they said about knowledge and awareness, I would screen hepatitis B for the following population groups. Cold communities. So cold is culturally and linguistically diverse communities, particularly if born overseas. 79% said that they would. So I don't find that massively reassuring. Like I would like if it said 99 or 100 there, whereas it says 99 for people who inject drugs. So I think that's interesting. So of a motivated group of general practitioners, not all of them are saying they would offer it to culturally and linguistically diverse people. So maybe not everyone is being offered the test. What about if you're offered the test? Why might someone choose not to have it if offered? So before, Kay was referring to how ancient hepatitis B is. And the thing that hepatitis B is ancient, and there are actually a number of genotypes for hepatitis B and subgenotypes, and we don't use them clinically, but when they look at them in the microbiology lab, fascinatingly, they can reveal patterns of human migration over time. And this is a graph, this figure demonstrates that. This is from colleagues at Vidril, and it's kind of showing different migration patterns. And these are ancient and parts of evolution. But what it kind of shows to me is that when people migrate, they take with them more than, their DNA and their, hepatitis B virus, but they take with them their experiences from elsewhere. Now, I'm going to get in trouble here because that is so small on my screen, I can't read it. And now I'm going to have to stand over here. And I might need new glasses, but that's all right. So these are two slides I've taken from the World Hepatitis Alliance, which is a global community organisation and peak body representing people who live with hepatitis. And this is a personal story of stigma. This is from Arafat, who's a public health worker from a rural part of Western Uganda. And when his uncle came to the hospital, he was diagnosed with terminal liver cancer resulting from hepatitis B infection. As well as the trauma of providing palliative care to his uncle, Arafat and his family faced an added burden of stigma and discrimination from the community associated with hepatitis B. And so I'm just going to skip to the black writing. My uncle's death wasn't the end of the story, remembers Arafat. The community decided to take revenge on my uncle's wife, subjecting her to gender-based violent attacks and eventually burning down her home. All the photos of my uncle were in that house and were destroyed in the fire. And so the concept of hepatitis B, which caused the cancer, wasn't accepted in this particular community. And here's another story. This is Liane, who found out that she was living with hepatitis B during a health screening, which was required before accepting a scholarship into a prestigious university. And her diagnosis changed her path, and she is now dedicated to breaking down barriers for people living with hepatitis B. So when she was at college, she secured a scholarship. And she was very proud because she was the first person from her village to have that opportunity to study overseas. And she had to do paperwork for the scholarship and a health check, and had a hepatitis test because of that. And when she got the results, the doctor at the health check told me I had hepatitis B and I would therefore not be able to go overseas. And I didn't know about hepatitis B. I did not question his advice. I blindly trusted him. I rejected the scholarship. It was only when I was older that I found out that the doctor was wrong. So for those who were recently at the viral hepatitis conference that was in Brisbane a few weeks ago, there were a number of presenters from overseas with lived experiences, and these stories are real. So we might be saying, oh, look, we've got a hepatitis B test. If it's positive, we can treat you. Don't worry about this. But for them, their experience, when we offer that, bears no resemblance whatsoever to what it is that we're suggesting. So how we have those conversations and how we make those two worlds meet, I think has yet to be broached. So then how do we test, and what about healthcare worker knowledge? And again, you've seen this before. We need 3 so-called ingredients to know someone's hepatitis B status. We need to know their surface antigen, core antibody, and surface antibody. And heaps of medical folk decompensate when trying to interpret hepatitis B serology. So that's why, if you can remember to write these 3 things on the slip, then all you have to do is type Hep B help into Google, and a chart on interpreting serology will come up. It's designed by the Doherty, and it's easy to interpret and will help remind you. And here's what I thought I had before. Obviously, before ordering a test, we would gain some consent. We would consider if the person needed an interpreter. We'd talk about the reason for the test and the personal implications of a positive result and the availability of treatment. And this is my take on interpreting the test results. So I think that my brackets haven't completely translated between Mac and PC, which is unfortunate, but we can cope. That will be all right. So the first 2 rows of this table belong with the blue bracket. And the people with these test results, their body has never seen hepatitis B virus. Hepatitis B virus has never been in their body. So either all 3 results are negative, which means that person is susceptible to the infection and they need to be vaccinated, or they've been vaccinated already, which means their hepatitis B surface antibody is positive. And there's that test in the blue. So that's meant to be all nicely sitting in the blue bracket, which has been moved in cyberspace. Then we should have 3 rows and we only have 2. So that's sad. And again, that is the 3rd row is in cyberspace. But what this means is all 3 rows on the bottom have a positive core antibody. And if you have positive core antibody, it means that your body has seen and in some way dealt with or not dealt with hepatitis B virus. And in the first red row, here, the hepatitis B surface antigen is negative. So I'm calling this resolved hepatitis B. And this is what the Doherty calls it as well. And in that second red row on the screen, we've got a positive surface antigen, and we're calling this active hepatitis B infection. And the last row, which doesn't exist in this world and is just in the cyberspace, is when you just have an isolated core antibody. And there's a number of possible explanations for an isolated core antibody. And I can talk through those if you want. I might leave that for questions, given we've lost our visual cue. Now, what's this whole core antibody positive mean? It means that your body has seen hepatitis B, and this is where it now resides, in the slightly off-center circle, moved by cyberspace as well. So as soon as your body has seen hepatitis B, it lives in your body forever. And it lives deep in the liver, is my explanation for it, in a hepatocyte. And there is the covalently closed circular DNA. And this is called hepatitis B CCC DNA. And for the people that have resolved infection, it means their immune system has managed to shut it down. The virus is not replicating. It's just going to sit there. No one will ever know about it. All we ever know is if their immune system gets shut off with chemotherapy, with end-stage AIDS, or something that involves massive immune shutdown. Otherwise, the infection is resolved, but their body has seen it and it still lives there. Whereas if there's active replication, there will be that surface antigen positivity. So this is the story of hepatitis B serology. And if we go back to what happens after the body is exposed, this is the story that Kay was saying before as well, that what happens depends on the age of the person and their immune system, in that baby's immune system and children's immune system doesn't have the ability to lock the virus up deep in the hepatocytes. And so there is ongoing replication and ongoing liver damage. So are healthcare workers good at interpreting serology? So let's go back to Yingzhong's survey that I referred to before of the GPs. And this particular item was about accurate interpretation of surface antigen positive, core antibody positive, surface antibody negative. So we know the person's seen, their body's seen hepatitis B, and they've got active replication, they've got active disease because they're surface antigen positive. So that means active hepatitis B infection. So 110 of 134 GPs that participated in the survey knew that was active infection. So 82%. So I don't know, I kind of wish that was 100, but it's not. So now we're up to linkage to care in our care cascade here. So this is the ideal world linkage to care, what we would like to happen. We would have community-based, accessible, culturally appropriate, supported by translators. And we would be taking into account, and these are words from my colleague, Jack Wallace, who's a social researcher at Burnett, that hepatitis B is perceived by doctors as an organ-based medical problem, whereas by people as an asymptomatic, intergenerational, often fatal infection with the capacity to socially marginalize both individuals and families. We would have the ability to conduct the medical workup, which is required, and the medical workup involves a measure of the level of viral activity, and that's the viral load and the E antigen of liver function, which involves liver function tests, an INR and an FBE. Of hepatic fibrosis, that's the amount of scarring. That's done with either serum markers or the FibroScan machine that I showed you in that picture earlier. And for other viruses. So there's alphabet soup here really for other viruses, but that's hepatitis A, hepatitis C, hepatitis Delta, and also HIV, and an assessment for pregnancy. And then family-based contact tracing would be pursued with vaccination of susceptible people. And we've referred here before to management. Management is hotly debated in many hepatitis B circles. So don't ask a bunch of hepatologists about it because you'll get a whole lot of different answers. But this is standard funded practice that most people with hepatitis B are monitored. So that means at least annually, they need to have a viral load. Some people with hepatitis B need to be monitored for liver cancer. So that means that they need to have 6 monthly ultrasounds and a blood test as well. And about 20% of people with infection need to have treatment. And treatment is entecavir or tenofovir. And both of these are 1 tablet once a day. Both are well tolerated. Both are taken indefinitely to suppress virus. So they're not curative. And both can only be prescribed by a specialist or by a hepatitis B S100 GP or nurse practitioner. And that's a very significant point that I'm going to circle back to shortly. And this is just reiterating, only 1/3 of people diagnosed with hepatitis B are having annual monitoring, and only half the people eligible for hepatitis B treatment are on it. And why? It's for all those barriers and reasons that we have just discussed, kind of falling down this care cascade. And lastly, access to care. So this is Western Victoria on a map. And actually, I've kind of cut the Grampians out of it. So I think it is the Barwon Southwest Public Health Unit on this map, actually. And it's got a number of dots on it. So the blue dots represent public specialists that can prescribe this medicine. So there's one blue dot, it's here. And so that's the clinic I run, it's the liver clinic. We run on a Wednesday morning between 9 and 12:30. So if you can't come at that time, we can't really see you. So that's the only public specialist clinic in this region. Then we move to green dots, they're private specialists. So most of these are out-of-pocket costs. So they will have their own individual standards about whom they bulk bill. And so there are private gastroenterologists and ID physicians in Geelong with variable waiting list times. And then there are also private gastroenterologists in Warrnambool. And then there's a community hepatitis nurse. So that's Inga, who's just walked in. She's going to talk to you in a minute. So she's the red dots. She does everything and she goes everywhere. She's going to tell you about that. But, you know, she goes to Warrnambool, Hamilton and Portland. That might be once every 6 or 8 weeks. So she's got to meet people there and hire rooms and go there. And then there are hepatitis B S100 GPs. I think there are 2. I've liaised with Vital recently to find out who these people are. I think there are 2. And I think one of them I know, and it's very difficult to get an appointment with him. The other one works, which is fabulous, works in the in Watherong, so the Aboriginal Health Service. So look, there's a really massive issue here about access to care. And I pinched this map from the first map I made for hepatitis C access to care in 2015, before the government changed the rules about hepatitis C prescribing. I'm going to get a yellow or red card any second. I think I know that, but I've nearly done. So it's very clear what we need to do and how we need to change things. So what can you do? You've all come here. That is brilliant. So you've started already to help us eliminate hepatitis B. You can learn more about hepatitis B affects different parts of our community, encourage testing and change. If you work in a practice, in a medical practice or a medical service, you can think about maybe how testing could be integrated into that service. You can know how to interpret hepatitis B serology and Google it if you forget. You can refer people that are hepatitis B surface antigen positive for care. And at the minute, I think that's probably our clinic. And we are really as helpful as we can possibly be within the limits of our service. And if you know someone has hepatitis B, please encourage them to attend their appointments or to have their blood tests if at all possible. Maybe you know a GP who might want to do an S100 prescriber course or attend yet another educational event. So here's an example of another educational event. So Vital, they've got a really long and complicated acronym, but it stands for Victorian Hepatitis and HIV Education something. I'm sorry, I can't remember their end of it. But they are run out of the Northwestern PHN, and they do all of the S100 prescriber courses and for nurse practitioners and for GPs as well. And there's a spotlight on hepatitis B coming up later in July, I think. These are some resources. I just thought I'd advertise this. It's a 2-page summary that can be printed as a PDF off the internet. This is made by ASHM, which is the peak body for, ASHM stands for the Australasian Society of HIV Medicine, but it's the peak body for BBVs in Australia. And lastly, conclusions. There is a long journey ahead to eliminate hepatitis B globally and locally. Increasing knowledge, testing and access to care are key issues. There has been a lack of investment in hepatitis B for a long time, and that's probably why we are where we are. But there is effective, well-tolerated treatment, which is fantastic. And to optimise engagement, we need to expand beyond the disease and organ-based model of communicating about this really important infection. And I'd like to acknowledge my colleagues from Bowen Health, many of whom are here, for Drug and Alcohol Services, Bowen South West Public Health Unit's in its infancy, but we're going to do all sorts of amazing work with hepatitis B, and also from the Burnett Institute. Thank you, and I welcome any questions.